So the treatment for CAORI is bilateral salpingo-oophorectomy, and if the cancer is grade 4 cancer, then after surgery, the patient requires chemotherapy as well. So this was all about ovarian cancer. So who will tell me the protective factors against ovarian cancer?
Pregnancy and OCP.
Yes, pregnancy and COCPs, because they decreases the ovulation. So that's why they are protective against COE. Now, a patient present to us with a sudden and severe unilateral iliac fossa pain plus nausea and vomiting. So before we discuss in detail ovarian torsion, can someone tell me the differential diagnosis of the three differential diagnoses of right iliac fossa pain, nausea and vomiting?
Appendicitis.
Appendicitis. Second one is ovarian torsion. Which is the third one?
Diverticulitis.
Diverticulitis present with left iliac fossa pain. Appendicitis, ovarian torsion, and
ectopic pregnancy.
ectopic pregnancy. Yes, that can also be a diagnosis, but in ectopic pregnancy, there will be history of amenorrhea.
EAC or pelvic abscess.
Kidney pain. Someone said kidney pain. Yes, renal colic can also present with these features, because the pain of renal colic can be referred from lumbar region to iliac fossa and to the groin. So how we can differentiate these three conditions on the basis of sign and symptoms? For appendicitis, the pain will start in the central abdomen or around the umbilicus, and then it will be shifted to right iliac fossa. And in kidney pain or renal colic, the pain will be referred to the groin region, while no such history will be given in case of ovarian torsion. Remember that the most important risk factor for ovarian torsion is cysts in the ovary, because if cysts are present in the ovary, it can lead to ovarian torsion. So a female with sudden severe unilateral iliac fossa pain plus nausea and vomiting and plus a tender mobile mass, then we'll suspect ovarian torsion. In ectopic pregnancy, there will be history of amenorrhea. So same features with history of amenorrhea will be ectopic pregnancy, and feature without any history of amenorrhea and a tender mobile mass, and then we'll suspect ovarian torsion. And how you can confirm ovarian torsion? You can confirm it by doing an ultrasound, which will show a large ovarian cyst with decreased vascularity because of twisting of the round ligament of the ovary, which is carrying the blood supply to the ovaries. So because there's twisting, so the blood supply to the ovaries will be blocked. That's why there will be a cyst with a decreased vascularity. So if we are suspecting ovarian torsion, then the important step is to refer for gynecology urgently. The biggest risk factor for ovarian torsion is cysts on your ovary. Cystic ovary can lead to ovarian torsion. Okay, our next topic is fibroids. Before we do fibroids, can anyone tell me the cause of the lower abdomen pain in females? What can cause lower abdomen pain in females?
PID,
PID, excellent.
UTI,
Any other condition?
urinary tract infection,
Please speak a little loud.
urinary tract infection,
Yes, urinary tract infection can also cause lower abdomen pain. And other thing
Menstruation?
that can cause low. Dr. Shafraz, what were you saying?
I said menstruation.
Yes, menstruation can also cause dysmenorrhea, can cause lower abdomen pain as well. So the important cause is pelvic inflammatory disease. The second important cause, gynecological cause of lower abdomen pain is fibroids. And the third one is endometriosis or adenomyosis. So we all know the features of pelvic inflammatory disease. Now we are going to discuss fibroids, how to differentiate clinically between fibroids and pelvic inflammatory disease. There are three types of fibroids: submucosal, subserosal, and intramural. Submucosal, which are present below the mucosa, that's why they are projecting into the uterine cavity. Subserosal, that are below the serosa, so they'll be projecting into the abdominal cavity. And the third type of fibroid is intramural, which is present in the muscle of the uterus. Submucosal fibroids, because they are projecting into the uterine cavity, so a hysteroscopy or hysteroscopic approach can be used to remove submucosal fibroids. And for subserosal and intramural fibroids, we need an abdominal approach to remove them. The commonest type of fibroids is intramural. What will be the features of fibroids? The most important feature for fibroid, because fibroids are basically benign smooth muscle tumor of the uterus. So as it is a tumor, so it can present with bloating, lower abdomen pain and bloating. So fibroids can also cause lower abdomen pain. Along with lower abdomen pain and bloating, there will be history of menorrhagia. And fibroids are more common in Afro-Caribbean women. Most of the time they are asymptomatic, but the important feature is that in Afro-Caribbean women with menorrhagia and bloating and lower abdomen pain, then you will suspect fibroids. Afro-Caribbean woman with menorrhagia and lower abdomen pain, you will suspect fibroids. Urinary symptoms can also be present. The diagnosis is made by transvaginal ultrasound. Transvaginal ultrasound will be confirm our diagnosis. Now, what is the management of fibroids? There is medical management and then there is surgical management. The best option for the management of fibroid is if the female does not want to get pregnant and the fibroids are small and do not distort the uterine cavity, then the best option is Mirena or IUS because it shrinks the fibroids. Whenever this type of question is asked in the exam, there will be some contraindication to the use of COCP will be mentioned. COCP can also be used in the management of menorrhagia, but when they want to choose you, Medina or IUS, a contraindication of COCP will be mentioned. So can somebody tell me what are the contraindication to the use of COCPs?
Migraine with aura.
Yes, migraine with aura is an absolute contraindication to the use of COCP.
Hypertension.
Hypertension, even if it's controlled, is a contraindication for Marina. Sorry, COCP. Any more contraindication?
Metabolic disorders.
Which disorders?
Thromboembolic disorders.
Yes, thromboembolism, obesity, smoking, etc. So if a woman has a history of pulmonary embolism, migraine with aura, we should avoid COCP because they are UKMAC3 in this condition. We should also avoid Mirena and Depo-Provera because they are UKMAC2. So if uterine ablation is given in the option, and then you will select uterine ablation. If a woman has a history of pulmonary embolism, migraine with aura, and she presents to us with menorrhagia or heavy menstrual bleed, and COCP, IUS, uterine ablation, Depo-Provera, they all are given in the option, then the best option will be uterine ablation. If the fertility is not an issue, if the woman family is complete, then we'll go for uterine ablation, uterine artery ablation. But if there is contraindication to the use of IUS or COCP or Depo-Provera, and the woman want to preserve her fertility, then we will go for myomectomy, which is the surgical removal of the fibroids. So a woman present to us with fibroids and there is no contraindication to the use of IUS, and the woman family is complete and she does not want to get pregnant currently, then Mirena is the best option. And if there's any contraindication to the use of Mirena, such as pulmonary embolism or migraine with aura, in these conditions, Mirena and Depo-Provera, they are UKMAC2. So if we can avoid it, then it's better to avoid it. And if uterine ablation is given in the option, then we'll go for uterine ablation. So both of these processes, and they affect the fertility. So you will not select these options if the woman is concerned about preserving her fertility. What are the options that you have if the female want to preserve her fertility? One option is myomectomy, and the other option is uterine artery embolization. So there are two methods which can affect the fertility, that is Mirena or uterine ablation. And there are two processes which can preserve the fertility. One is myomectomy and the second one is uterine artery embolization. Myomectomy is surgical removal of the fibroid, and uterine artery embolization is a process in which if the fibroids are less than 3 centimeters in diameter, then this option can also be used, but it is less effective than myomectomy. So if a woman is concerned about the fertility, so myomectomy is still the first line treatment. The second line, if the woman wants to preserve the fertility and the fibroids are less than 3 centimeters in diameter, then uterine artery embolization can also be done. GnRH agonists can also be used to shrink the fibroids before surgery. GnRH agonists, when they are given as a continuous therapy, they can suppress the estrogen production, estrogen and progesterone production. So that's why they can lead to shrinkage of the fibroids, and they may be useful if the patient is undergoing a surgery. So they will shrink the fibroids and they will be easy to remove. So in short, we have 4 options: 2 that affects the fertility, that is IUS and uterine ablation; 2 that can preserve the fertility, that is myomectomy and uterine artery embolization; and 1 is the most successful option, and that is hysterectomy, if you remove the uterus altogether. The role of GnRH agonists is that they can be given before surgery because they can shrink the fibroids. Myomectomy is abdominal myomectomy is done if the fibroids are intramural or subserosal, and hysteroscopic myomectomy is done if the fibroids are submucosal. So pelvic inflammatory disease and fibroids, they can cause lower abdominal pain, or they are the gynecological causes of lower abdominal pain. A third cause of lower abdominal pain or gynecological cause of lower abdominal pain is endometriosis. So can somebody, you all remember that the differentiating feature for PID is fever and cervical motion tenderness along with lower abdominal pain. For fibroids, it's menorrhagia in an Afro-Caribbean woman with lower abdominal pain. Now, the third one, important gynecological cause of lower abdominal pain is endometriosis or adenomyosis. What is endometriosis? Endometriosis is a growth of ectopic endometrial tissue outside of the uterine cavity. Endometrial glands are present outside the uterine cavity. If endometrial glands are present within the myometrium, muscular layer of the uterus, then it is called adenomyosis. So endometrial tissue, either outside the uterine cavity or inside the muscular layer or myometrium. So if they are outside the uterine cavity, they are known as endometriosis. And if it's inside the myometrium, then they are known as adenomyosis. The clinical features of endometriosis or adenomyosis, they are similar to pelvic inflammatory disease. That is lower abdominal pain, dysmenorrhea, deep dyspareunia, subfertility. Only cervical motion tenderness will not be present in case of endometriosis and adenomyosis. And the second thing that that can differentiate it from pelvic inflammatory disease is that in endometriosis, the pain is cyclical. The pain is cyclical. It starts and ends with the periods. So these are some differentiating features between PID and endometriosis or adenomyosis. So if you're suspecting endometriosis, then laparoscopy is the gold standard or most definitive investigation. While if you're suspecting pelvic inflammatory disease, then what is the investigation of choice? Who will tell me?
Endocervical swab.
Endocervical swab, excellent. And if you are suspecting tubo-ovarian abscess, which is a complication of untreated pelvic inflammatory disease, then what is the investigation of choice?
Ultrasound of pelvis.
Yes. And if we are suspecting adenomyosis or endometriosis, then laparoscopy is the gold standard or most definitive investigation. Not hysteroscopy, because the abnormal uterine tissue is lying outside the uterus, so hysteroscopy is not going to help in the diagnosis of endometriosis. The management is simple. The patient can be managed with NSAIDs or paracetamol. They are the first line treatment for symptomatic relief. If analgesia does not help, then hormonal treatments such as a trial of COCP or progesterone, such as methoxyprogesterone acetate, should be tried. So before surgery, we should try the medical treatment, that is NSAID or paracetamol, they are first line. And if there is no relief with the use of these medicine, then a trial of COCP or progesterone or methoxyprogesterone acetate can be tried as well. They should be given for at least 3 to 6 months before laparoscopy, as long as the fertility is not an issue, because all of them are contraceptive. So if a female is concerned about her fertility and she want to get pregnant, then you cannot give COCP or progesterone or methoxyprogesterone acetate. Then you will go directly for laparoscopy or laparoscopic removal of the endometrial tissue. Otherwise, if the fertility is not an issue, then you should try hormonal treatment for 3 to 6 months before doing laparoscopy. So simply, the medical management is through ovarian suppressions, that is through COCP or TNRH agonists in Mirena. And the other option that we have is surgical removal of the endometrial tissue. The only thing that you need to consider is that if the woman is concerned about her fertility or if fertility is not an issue, to decide between surgery and medical treatment. 5 Ds of endometriosis: dysmenorrhea, dyspareunia, dyschezia, dysuria, and dull chronic pelvic pain. These features are similar to that of pelvic inflammatory disease. The only difference is that pelvic inflammatory disease has fever and cervical motion tenderness as well. Plus, there will be history of some risk factor of sexually transmitted infections such as multiple or new sexual partners will be mentioned. Remember that IUS or IUD is a risk factor for pelvic inflammatory disease, while it is a treatment for endometriosis or adenomyosis. So remember this difference as well. And IUS in place will improve the symptoms of endometriosis or adenomyosis, while it is a risk factor for the development of a pelvic inflammatory disease. Normal ultrasound does not exclude endometriosis. That's why laparoscopy is the gold standard investigation. So we have discussed the causes, gynecological causes of lower abdomen pain. That was PID, fibroids, endometriosis or adenomyosis. Now another cause of pelvic pain or chronic pelvic pain is pelvic congestion syndrome. Pelvic congestion syndrome is also known as pelvic vein incompetence. It is a chronic medical condition in women caused by varicose vein in the lower abdomen. So you have heard about varicose vein in the legs. Pelvic congestion syndrome is caused by incompetent vein in the abdomen, which leads to a pooling of blood in the abdominal veins. So the patient will develop a chronic pelvic pain. How you can differentiate it from PID and other causes of lower abdomen pain? It's very easy to differentiate. Remember that the pelvic pain and pelvic congestion syndrome will be aggravated by standing, and it will get relieved when the woman lie down. So if the patient, the pain character changes with position, then it is most likely pelvic congestion syndrome. The pain that is aggravated by standing and that is worse at the end of the day after a long period of standing, and the sufferer get relief when they lie down, then the diagnosis will most likely be pelvic congestion syndrome. So chronic pelvic pain that worsen by standing and worsen premenstrually. So you can see that the pain of endometriosis is also associated with menstrual cycle. So the differentiating feature that you need to remember for pelvic congestion syndrome is that the pain is worsen on standing, and it is worse at the end of the day after a long period of standing, and the sufferer get relief when they lie down. So this point is important to remember to make a diagnosis of pelvic congestion syndrome. Ultrasound will be normal. Laparoscopy will also be normal. All the investigations will be normal because there is no organic cause. There is only problem in the veins. The walls of the veins are not incompetent. They are incompetent. So that's why the patient developed chronic pelvic pain. So all the investigation will be unremarkable. The definitive treatment for chronic pelvic congestion syndrome is to shut off the damaged vein by sclerotherapy or embolization, or surgery to remove the damaged vein, or even surgery to remove uterus or ovaries can also be done. So this was all about some causes of lower abdomen pain. So pelvic inflammatory disease, fibroids, endometriosis, and pelvic congestion syndrome. These are some important gynecological causes of pelvic pain. Now, the next topic is it clear everyone up to this point? If someone want to ask any question, then he or she is welcome to ask.
So I had a question on fibroids. Is there any change of management according to the different level of the fibroid, whether it's subserosal, submucosal? Would we manage it differently?
Can you please repeat your question because I didn't hear the first part?
In the management of fibroids,
Yes.
does the management change according to the location of the fibroid, whether it's intramural or subserosal or submucosal?
Management is same, just approach is different. If they are subserosal or they are intramural, it means they cannot be removed through a hysteroscopic approach, through transvaginal approach or hysteroscopic approach, because hysteroscopy is inserted through vagina. So the fibroids that are projecting in the abdominal cavity, they can only be removed through an abdominal approach, that is abdominal myomectomy. Procedure name is same, that is myomectomy, only the approach will be different. If they are submucosal fibroids, they project into the uterine cavity. So they can be removed through a hysteroscopic approach. So hysteroscopic myomectomy is done in case of submucosal fibroids, and for intramural and subserosal abdominal myomectomy is done.
And sir, is there a role of POPs, progesterone only, in fibroids?
Yes, progesterone containing drugs can shrink the fibroids. IUS is also a progesterone containing drug. So if a woman is looking, her family is complete and she does not want to get pregnant currently, and then IUS is the best choice. Otherwise, POPs can also be used.
Okay, thank you.
Doctor, I have a few questions regarding the management of fibroids.
Yes.
The thing is, if the patient doesn't want to be pregnant, so the definitive management would be myomectomy, right? And then you told about uterine artery embolization as well. So which should I prefer, myomectomy over this embolization?
Myomectomy is the first line because myomectomy has better results, and uterine artery embolization is not that effective. So if both of them are given in the option, then you will prefer myomectomy.
Okay, is there any indication so that we can go for this embolization over myomectomy?
No, there is no specific indication. You will always choose myomectomy between the two. But if myomectomy is not given in the option and a uterine artery embolization is given in the option, and the woman is concerned about the fertility, then you will select uterine artery embolization.
Okay, doctor. And another question what I'm having that regarding endometrial ablation, when our COC, POP, Mirena are contraindicated and patient doesn't want to be pregnant, and we might go for endometrial ablation when the fibroid less than 3 centimeter, right?
Yes.
Okay. So if more than 3 centimeter, then what should be the management?
Then hysterectomy will be done.
Hysterectomy. Okay,
Yes.
doctor. Thank you very much.
You're welcome. So what is premenstrual syndrome? These are emotional and physical symptoms that a woman may experience prior to menstruation. These symptoms include anxiety, stress, fatigue, and mood swings. So if there is no contraindication to COCP, premenstrual syndrome can be managed with COCPs. The next topic is hormone replacement therapy. Hormone replacement therapy, there are two types of hormone replacement therapy. One is cyclical and one is continuous. Remember that cyclical hormonal replacement therapy, the indication to use a hormone replacement therapy is if the patient is having a postmenopausal symptoms or vasomotor symptoms such as hot flushes and sweating. So now when we'll go for a cyclical hormone replacement therapy and one will go for continuous hormone replacement therapy. So in menopausal women, continuous hormone replacement therapy is required, while in perimenopausal women, the women who are close to their menopause but they are still menstruating, but their periods are irregular. So in perimenopausal women, cyclical hormone replacement therapy, and in postmenopausal, continuous hormone replacement therapy. Because if the woman is still menstruating, then it means there are some levels of estrogen and progesterone hormones. So that's why we need to give cyclical hormone replacement therapy, in which in the first 14 days estrogen is given, and for the next 14 days progesterone is also added. in the treatment. So in simple words, menopausal women who have 12 consecutive months of amenorrhea will prescribe continuous hormone replacement therapy if she is having vasomotor symptoms such as hot flushes and sweating. And if the woman is still menstruating, but her menses are irregular or heavy near the age of 50 or above 45, then we'll use cyclical hormone replacement therapy. Now, there are two other types of hormone replacement therapy that is combined hormone replacement therapy and estrogen only hormone replacement therapy. Usually due to the patient usually develop the symptoms due to a deficiency of estrogen, but we add progesterone because estrogen can cause endometrial carcinoma